Thank you, Mr. Watkins. Ms. Underwood, you're recognized.
Thank you, Mr. Chairman. As a public health nurse, I know just how important it is to advance solutions to the veteran suicide crisis that are data-driven and that are evidence-based. Identifying strengths and weaknesses in VA care allows us to focus on those areas that require the most immediate attention. And one of those areas is mental health and suicide prevention workforce. I understand that vacancy rates among mental health clinical staff are critical challenges facing many of our communities, including some at VA facilities. So at the outset, I will say that I know that just in the community-based setting, this is a problem, okay? What actions, Ms. Oshinsky, is VA taking to retain staff and fill vacancies in the mental health and suicide prevention space?
Thank you for that question. One of the things that we try to do, again, is make sure that people are very well oriented so that they understand exactly how they are going to interact in that situation.
Oh, yes, ma'am. I'm sorry. We have a limited time. So just honestly, what are you doing to fill the vacancies, if you can?
What are we doing to fill vacancies? We have open and continuous hiring so that we never close a vacancy. We continually put that out there so that anytime anybody wants to apply for a job, they have that opportunity. It doesn't mean that a vacancy has to exist, so that we would constantly have people able to step in, that they would already be qualified and we could hire them, overhire them. And that's something that we do on a routine basis when we can do it. Unfortunately, as you know, often there's a gap and we don't have those. But open and continuous is certainly one of the things that we've done to improve hiring.
Okay, thank you. Another area is lethal means training. Research backs up the life-saving benefits of creating additional space and barriers between a veteran who may be experiencing suicidal thoughts or ideations and the lethal means for them to complete any suicidal action. It's my understanding that VA has implemented lethal means training for all VA mental health care clinicians who interact directly with veterans. Dr. Carroll, is that correct? And can you confirm exactly which categories of VA staff are currently receiving the lethal means safety training?
I will have to get back to you about which categories of employees across the board, but yes, all mental health providers would be required to receive that training.
Okay, and in that response, can you please outline like clinical and if there is any non-clinical staff that are receiving that training,
Yes,
and whether it's voluntarily offered or a requirement?
Yes.
And sort of some of the details around that training would be very helpful. Can you also tell us more about the training that the VA has developed? Like how often do staff have to receive it, things like that?
Yeah, the lethal means training is not currently an annual requirement, but I think the frequency of training we will get back in our response to you.
Okay.
We've also developed a lethal means training that's available widely in the community in partnership with the American Foundation for Suicide Prevention, as well as the National Shooting Sports Foundation.
And then to develop that training, was that something internal to VA, or did you work with outside experts?
We worked with outside experts.
Was it just the Sports Foundation or other?
And the American Foundation for Suicide Prevention.
Okay. And then what's your understanding of the lethal means safety training that contractors receive? And would you say that it's equivalent to what the staff receives?
Well, I would like to take that for the record so we
Okay.
make sure we get you the correct information.
Thank you. In some instances, some of the veterans in crisis no longer require inpatient care or supervision by the medical staff at the VHA centers. This requires a handoff to another responsible party. It might be the veteran's family or other members of that veteran support network. So Dr. Carroll, what resources are available to families and the support networks for the veterans that are at risk of suicide? And are they able to coordinate with the veterans' clinicians? Are they able to access trainings or any other educational resources provided by the VA?
Yeah, certainly family members are part of the team that cares for veterans, and we respect veterans' wishes in terms of having family members engaged in their care, but to the extent that they are supportive of that, we welcome them into the care process. We also have resources available to family members just like they are available to veterans, such as the Veterans Crisis Line. We also have a program called Coaching into Care, which is a specific resource for families to call, in particular if their veteran may be hesitant or reluctant. It will help the family kind of understand what some of the resources are and how they can maybe help that person towards getting into care.
Well, I appreciate that, but that's on the front end. I'm talking about after someone's already received care at the VA.
Yeah.
say they've completed an inpatient stay and they need to be discharged, there needs to be some kind of handoff.
Yes.
And to likely a community provider, what we're seeking to understand is the type of coordination that's offered in that handoff and information that's being shared to both family and other clinicians in the community or support networks, of which there are plenty. In many communities around our country. So can you speak a little bit about that? I know I'm out of time, so maybe you can take that for the record if the chairman would allow him to answer. Okay, if you would answer.
Yeah, so families, there should be a warm handoff when someone leaves a inpatient unit to make sure that they have an appointment, for follow-up, and they understand. And in many cases, the provider, if it's within our facility, may come onto the unit and may see that patient already, or have an existing relationship, and the family member should be involved. If they're going to the community, that community provider needs to acknowledge that they have an appointment, and then we would need to follow up to make sure that that handoff actually occurred.
Okay, so then for the record, then we'll probably submit a question, because I think I heard you say that the community clinician is allowed in before that handoff occurs to the VA facilities. Just want to really drill down on that along with the other questions that we had. Thank you so much to our witnesses for being here.